right now we're looking directly at TB-500 and BPC-157, which are easily the two peptides most frequently stacked together for injury recovery. But to really figure out which one of these to use, or if they should even be combined at all, we have to look at how they actually function at a cellular level. We're basing this analysis entirely on clinical evidence and documented mechanisms, completely setting aside the online hype to focus strictly on the medical reality of what these compounds do. Our roadmap for this analysis is pretty straightforward. We'll trace the path from cellular molecular mechanics directly into target applications, cover specific dosing protocols, and then move heavily into safety. We'll address patient tolerability, the actual reality of tumor risks, the very strict long-term safety limits, and wrap up with the rigid 2026 regulatory guidelines. Understanding the distinct mechanisms and target applications, specifically this idea of systemic versus local healing, is absolutely critical before you even consider choosing a peptide. So TB-500 works through a process called G-actin sequestration, which essentially speeds up cell migration throughout your entire body. Because it circulates systemically, it has this incredibly unique ability to act on every active injury site all at once. It's like a general contractor roaming the entire project site. BPC-157, on the other hand, is a local worker. It primarily boosts VEGF and collagen synthesis right where you inject it, building up the immediate local infrastructure. Now, what's really interesting about this slide is the stark contrast in clinical evidence levels and biological derivation. TB-500 is derived from a human protein with evidence actually reaching phase 3 randomized controlled trials for corneal healing using full T-beta-4, along with a phase 2 cardiac study. The typical loading dose is 2 to 2.5 milligrams twice a week. BPC-157, however, is derived from a protein found in rat gastric juice and relies entirely on animal models. Typical dosing for that is 250 to 500 micrograms once or twice a day. You'll notice both face strict WADA bans in 2026, though under different categories. Because of that systemic circulation we just talked about, TB-500 is the clear, logical choice when an injury is deep or practically impossible to reach with a localized needle. Think spinal injuries, deep hip issues, or cardiac tissue recovery. It is also the ideal path when you're dealing with multiple injuries in totally different locations at the exact same time, or when your recovery involves systemic, full-body inflammation rather than just a single isolated problem. In comparison, BPC-157 is highly effective as a first step for easily reachable areas, like an acute tendon injury in the knee, shoulder, elbow, or ankle. Also, because its strongest documented effects are actually in the gastrointestinal tract, taking it orally or interperitoneally, which means injected directly into the body cavity, is the preferred approach for gut healing. It's also utilized for targeted neurological issues through localized administration routes. Now, to be clear, neither peptide currently has human randomized controlled trial data for musculoskeletal use, so the clinical gap is roughly the same for both. This perfectly tees up the Wolverine Stack protocol, which is a dual mechanism recovery approach where we can see exactly how these two distinct healing pathways combine to cover sequential steps in the tissue repair process. The operating theory here is quite straightforward. BPC-157 builds up the local blood vessel infrastructure, and then TB-500 helps drive repair cells directly through that newly built infrastructure. The protocol begins with BPC-157 administered subcutaneously at 250 to 500 micrograms once or twice a day, injected near the injury. Concurrently, the TB-500 loading phase utilizes 2 to 2.5 milligrams subcutaneously, twice a week, but crucially, this is injected away from the injury. The lower abdomen or outer thigh works perfectly. Following that loading phase, TB-500 shifts down to a maintenance dose of 2 milligrams once a week, while BPC-157 is often continued daily throughout the whole cycle. Now, listen closely to this. You absolutely cannot mix TB-500 and BPC-157 in the same vial. They must be reconstituted and stored completely separately. They require entirely different concentrations, and there is zero documented study verifying whether a combined solution of the two remains stable. So keep them separated. Shifting focus to patient tolerability, common side effects, and reactions, it's vital to establish a solid baseline so you know exactly what minor reactions to expect when introducing these compounds. For TB-500, the vast majority of reported side effects are exceptionally mild. The most common complaint by far is just an injection site reaction, mild redness, swelling, or a bit of discomfort. Simply rotating your injection sites effectively cuts this down. Additionally, some individuals experience a wave of fatigue during the first 2 to 5 days of a new cycle, which clears up entirely on its own. An occasional mild headache might also pop up in the first few days, though case reports do not suggest this is tied to the dosage amount. Ultimately, these are transient and generally do not require stopping the protocol. So, the crucial point is knowing exactly when a reaction crosses the line from mild to severe. You must stop administration and see a physician immediately. If you experience a high fever after an injection, blistering, hives, or severe itching, which indicates possible anaphylaxis. Also, persistent vomiting, swelling that spreads well beyond the injection site, or any chest pain and heart palpitations. While these are rare in practitioner literature, they mandate immediate medical intervention, no exceptions. We have to bridge the discussion away from basic cellular repair now and evaluate the heavy medical reality of cancer risk, specifically looking at angiogenesis and solid tumors. Angiogenesis is simply the biological formation of new blood vessels. Ironically, this is the exact mechanism that powers TB-500's therapeutic benefits, but it's also the exact reason the theoretical cancer concern exists. You see, solid tumors absolutely require angiogenesis to grow past about 1 to 2 millimeters in size. The worry here is that if TB-500 promotes general blood vessel growth, it could inadvertently build the blood supply that feeds an existing undetected tumor. Looking directly at the evidence, T-beta-4 expression does indeed go up in several cancer types in preclinical models, specifically liver cancer, colorectal cancer, and head and neck cancers. This was thoroughly noted in a 2021 study by Zing and colleagues. However, the direction of causation is totally unclear. Higher T-beta-4 levels might simply be a biological response to the tumor's presence, not the driver of its actual growth. To date, no animal study has shown TB-500 or T-beta-4 causing cancer at standard doses. Furthermore, no human study has documented TB-500 causing cancer or accelerating tumor growth. To put it as plainly as possible, don't confuse a theoretical worry with a documented clinical risk, but don't ignore the theoretical worry either. The mechanistic concern is entirely real, even if clinical evidence for actual harm remains absent. When looking at long-term safety limitations, we run into a massive data gap. We really need to talk about the absolute limits of current medical data and what happens when users stack continuous cycles. 180 days. That is the absolute longest published human safety window for T-beta-4. This number comes directly from the 2016 cardiac pilot study by Zhu and colleagues. To be clear, there is not a single published study tracking TB-500 or T-beta-4 use in humans for a full year or longer. Operating continuously beyond that 180-day limit means you are flying completely blind. Angiogenic effects that appear perfectly safe over a 12-week span could behave drastically differently after 2 or 3 years of repeated cycles. The immune effects from long-term peptide exposure are largely unstudied. On top of that, the AC-LKKTE metabolite, which is a specific chemical byproduct identified recently in 2024, has not been checked for long-term buildup in the human body. Running continuous back-to-back cycles means doing so with zero safety reference data. And beyond the peptide's own safety profile, unverified compounding introduces incredibly severe independent risks. FDI inspections of compounded and research-grade peptide products have repeatedly uncovered massive rates of inaccurate dosing and outright contamination. We are literally talking about bacterial endotoxins, leftover solvents, incomplete peptide chains, heavy metals, and microbial contamination. Endotoxins in particular are a massive injection risk. They can trigger a body-wide inflammatory response, and in high enough doses lead straight to septic shock. Moving into the final stage of our analysis, we have to establish the absolute legal boundaries and the specific medical situations where these compounds must be avoided entirely heading into 2026. Both peptides were recently removed from the FDA's Category 2 list, though they took different procedural paths to get there. For instance, TB-500 was removed in April 2026 after the original nominators withdrew their submissions, and both are still facing ongoing reviews for potential Category 1 placement. But for athletes, the rules are set in stone. The 2026 World Anti-Doping Agency prohibited list places BPC-157 under S0, covering non-approved substances. TB-500, however, is classified under S2, which covers peptide hormones and growth factors due to its documented structural connection to thymosin beta-4. Ultimately, both classifications result in an absolute prohibition for competing athletes. And this brilliantly illustrates why understanding mechanisms is so critical. Because of angiogenesis, TB-500 is absolutely contraindicated for anyone with active or suspected cancer, or anyone actively undergoing cancer treatment. It directly conflicts with the mechanism. If you have a recent cancer history, it requires a physician's decision based on stage and treatment. There is zero human safety data for pregnancy or breastfeeding, and because T-beta-4 plays a role in embryonic development, its growth factor activity makes it strictly off-limits. Lastly, while it has been studied for stable post-heart attack patients, using it during an active cardiovascular event without a physician's direct supervision is strictly outside any validated protocol. We are looking at a truly profound capability for cellular recovery here, weighed directly against a strict 180-day safety limit and the incredibly high stakes of unregulated compounding risks. So, looking at these massive clinical gaps between healing potential and missing long-term safety data, how will we safely navigate the future of peptide therapies?